Reproductive Medicine at Bansal Hospital under Dr. Priya Bhave ma'am. I welcome all of you to the SUFLA program organized in association with IMA Betul and MPIFS chapter and Obstetric Society Betul. The topic of today's webinar is second trimester markers. I would like to invite Dr. Tina Gupta ma'am for the introduction of the webinar. Dr. Tina Gupta ma'am.
Yeah. Good evening, everyone. Yeah, I would like to just give a brief introduction to this webinar series. I am giving this introduction on behalf of Dr. Priya Bhave. This SUFLA is an initiative by the MP chapter in Indian Fertility Society. I would like to thank Dr. Smita Dengle ma'am for giving consent to take this responsibility of heading this wonderful webinar series. SUFLA is a webinar based on the important topic of managing pregnancies conceived after infertility treatment and IVF. Today's webinar is third in row. In first webinar, we have covered topic early pregnancy scan, basics and beyond. In second webinar, we have covered first trimester screening. And in today's webinar, we are going to cover second trimester markers. I request Dr. Neha to start the proceedings.
Thank you, ma'am. Now I invite Dr. Sushmita Mukherjee ma'am for the introduction of MPIFS chapter. She is IVF consultant and laparoscopic surgeon at Indore, and she is executive at the IFS MP chapter. Over to Sushmita ma'am.
Thank you for the introduction. And will you please share the presentation?
Shilpi, please share the presentation.
Now, today my responsibility is to give you details about the activities of IFS MP chapter from November 2020 to January 23. And not only January 23, it will include even the program which was held last week, last Sunday. It was a physical meeting on quality control of IVF lab, and it was very, very successful under the leadership of Dr. Priya Bhave, our secretary. A lot of activities have been done, and all the members and the local societies, they have participated, and it is rather brainchild of Dr. Priya. Lot of things. She is a very great organizer and a great academician too. And she has planned all these activities in a very nice manner. And IFS MP chapter has done a lot of academic activities. So today I will be giving you details of that. So the programs which are held under IFS MP chapter are Sudiksha, Safal and Sufada, Supraja, Masterclass and Webinar. Let's begin. So under Supraja, awareness campaign under IFS banner, awareness campaign for various schools and colleges, and knowledge imparted regarding menstrual hygiene, vaccines, hypothyroidism, etc. And at Indore, it was conducted by Dr. Bela Shah Jain on 23rd November at Bijalpur Indore Girls Higher Secondary School. At Bhopal by Dr. Priya on 29th November at Bhopal Sage Group, and at Ujjain, it was conducted by Dr. Anuradha Pancholi with the DPS program coordinator. At Bhopal, at Rajiv Gandhi College, and Dr. Tina Gupta was the program coordinator. At Riva, it was done by Dr. Kundan at Riva Medical College. At Indore, Vijalpur Indore Girls High Secondary School by Dr. Shweta. At Dindori, again, Dr. Priya had gone, and she conducted the program. At Indore, also at Indore High Secondary School, the program coordinator was Bela Shah Jain. Supraja Awareness Program on 16 February was conducted by Dr. Priya at Bansal Hospital, Bhopal. At Gwalior, 19 February, Atma Jyoti School, and the coordinator was Dr. Snehata Dubey. At Gwalior, it was conducted by Dr. Pratishtha Dalmia at Gwalior RJ Apollo Spectra Hospital. Again on 17th of March, it was conducted at Bhopal Bansal Hospital by Dr. Priya Bhave. Sudiksha, MP Chapter IFS Postgraduate Masterclass in Reproductive Medicine. It is a 6-hour program which covered anovulation, where assessment and management regarding anovulation was done, HSG, how to perform and interpret, evaluation of male partner and interpretation of semen analysis, laparoscopy in infertility, genital tuberculosis in infertility, unexplained infertility, IVF and embryo transfer, what, when, how, and hyperprolactinemia and thyroid disorders in infertility. So Sudiksha Jabalpur introduction. Sudiksha, postgraduate CME in reproductive medicine for PG students, was held on 23rd January at NSCB College, Jabalpur. Over 63 postgraduates attended, and there was an enthusiastic response from an entire faculty and audience. Dr. Kavita Singh, HOD, gave us full support, and CME was coordinated by Dr. Kunjan Goswami and Dr. Dikti Gupta. Sudiksha Indore was held at SAIMS, Sri Aurobindo Institute of Medical College. Reproductive medicine for PG students held on 5th of February at SAIMS College, Indore. Over 57 postgraduates attended, and there was an enthusiastic response from entire faculty and audience. Dr. Neeta Nahattu, HOD, gave us her full support, and CME was coordinated by Dr. Shilpa Bhandari and Dr. Shruti Paliwal. Sudiksha Riva was where the postgraduates underwent the CME on reproductive medicine. Over 33 postgraduates attended, and there was an enthusiastic response. Lectures were delivered by Dr. Binu Pushpa, HOD, Dr. Gunjan Goswami, Assistant Professor, and Dr. Sumanal Agarwal, and the session was also taken by Dr. Priya Bhave Chittawar, HOD, Reproductive Medicine, Bansal Hospital. Sudiksha Bhopal, MP Chapter IFS, in coordination with Department of Obstetrics, Ellen Medical College, Bhopal, presented Sudiksha program of postgraduate CME on reproductive medicine on 25th of February. It was joined by our President, Dr. K.D. Nair sir, Dr. Nalini Mishra, Dean of Ellen Medical College, Dr. Aruna Kumar, HOD of Obstetrics, GMC Bhopal, Dr. Gurpreet Kaur, HOD, People's Medical College, Bhopal, Dr. Pooja Patil, HOD of Obstetrics, Ellen Medical College, Bhopal. Dr. Priya gave idea regarding approach to infertile couple and had another session on topic anovulation and ovarian induction and stimulation. Male factor infertility was thoroughly taught by Dr. K.D. Nair, HSG, and its interpretation was presented by Dr. Nishi Mishra. An idea regarding baseline USC was given by Dr. Devanshi Mishra. A tour inside IVF lab was done by Dr. Sonal Jain. Training opportunities in reproductive medicine was told by Dr. Tina Gupta. Other than the above mentioned talks, the program involved role play by PG students of Ellen Medical College, and quiz was also held for PG students. Almost 80 audiences were there, including 70 plus PG students of different medical colleges of Bhopal, and it was a huge success. Sudiksha Bhopal MP chapter IFS in coordination with Department of Obstetrics of GRMC Medical College Gwalior presented Sudiksha program, a postgraduate CME on reproductive medicine, and it was joined by Dr. Survin Gunman Madam, General Secretary IFS, Dr. Vrunda Joshi, HOD of Obstetrics, GRMC Medical College, Dr. Pratibha Garg, Professor of Obstetrics, GRMC Medical College, Dr. Pratishtha Dal, Executive IFS Member, MP Chapter, and Dr. Sonali Agarwal, Executive IFS MP Chapter. Dr. Priya Bhavi Chittagar gave idea regarding approach to infertile couple and had another session on topic anovulation and ovarian induction and stimulation. Now, Sufala, a series on managing pregnancies after infertility treatment and ART, and it was a session on early pregnancy scan, basics and beyond. In the series, the second day event was first trimester screening and another second trimester markers. Master classes which were held under the banner of MP chapter IFS. Unique master class on fibroids and infertility on 14 December 22. Topics on 11 January, genetics in reproductive medicine, on 25th January, unexplained infertility, and on 1st February, basics of hysteroscopy. And on 9th February, peri-implantation genetic testing. Masterclass MP chapter IFS also another masterclass male infertility was held on 1st of March 2023 and on 15th March on IVF in PCOS. IFS webinars, role of hysteroscopy in safe yet effective use of gonadotropins. It was held at Hoshangabad on 12th November. On 28th November at Sagar. On 28th January at Pune. And 27th November at Bhopal, there was a CME with the Bhopal Obstetrics Society and MP chapter IFS on infertility, and there was a fellowship award ceremony also. CME on 27th December at Chhatarpur. It was on infertility and endocrinology. It was along with Indian Medical Association, Chhatarpur, and IFS MP chapter. Sometimes it is getting stuck. I don't know why. Now the CME on 12th February 2023 at Viva, and let us come to this very important program of award ceremony by MP chapter IFS at Hotel Taj Bhopal on 4th of February, and various awards were given, and our President and Secretary General both were present. March endometriosis, as we all know, March is endometriosis awareness month. So IFS MP chapter has organized various programs for the awareness of endometriosis, and these are at Bhopal on 1st of March. Under the aegis of MP-IFS celebrated Endometriosis Awareness Month on 4th of March at EIMR Nursing College, Gwalior by poster competition on endometriosis and awareness talk by Dr. Shivala Bhusle Madam, President Gwalior of Gynae Society. Apart from winners, all participants were distributed certificate of participation and program coordinator Dr. Snehata Dubey, member MP-IFS Gwalior. So various awareness programs were organized by various members of IFS MP chapter, Dr. Anuradha Pancholi at Ujjain, and Dr. Priya. Indo-March, a rally and awareness session for endometriosis awareness was held on 12th March 2023 at Bhopal under MP-IFS and Bansal Hospital. 116 healthcare providers attended the march and a yoga session was held. An awareness session about endometriosis was held and symptoms and management of endometriosis with special focus on early detection was taken. The color of the endometriosis awareness is yellow, and to symbolize this, all participants wore yellow. And that was what we were directed by our secretary, and every member who has organized the program would wear a yellow along with the staff and whoever attended the program. Dr. Pratishtha Dalmia at RJN Apollo Spectra and Ratan Jyoti Dalmia Heart Institute, Gwalior, her program for the endometriosis awareness activity. The endometriosis awareness drive by MP chapter IFS continued with Dr. Shweta Agarwal on 16th of March. Also, it was done by Dr. Hina Agarwal at Indore on 16th of March at ILC Fertility and IVF. Dr. Gunjan Goswami from Riva organized an endometriosis awareness at Riva on 18th of March. Another activity on 18th of March done by me in my center. March Endometriosis Awareness Program, MP Chapter IFS and Viva of Gynae Society organized a CME at Viva on 19th of March, where 47 speakers, participants and 47 speakers like Dr. Tanya Mahindra, Dr. Padma Shukla, Dr. Manisha Srivastav, Dr. Priyanku Roy, and moderator was Dr. Gunjan Goswami and Dr. Padma Shukla. It was a very, very nice program. The endometriosis awareness drive by IFS MP chapter continued with Dr. Devangshi Mishra, where creating awareness on women's wellness with yet another Supraja outreach program organized at Sagar Public School, attended by over 70 staff members, and the initiative was very well appreciated. Another endometriosis awareness program was organized by Dr. Sonal Jain on 23rd of March at Sirayu Medical College, Bhopal. MP chapter IFS and Special Interest Group Quality Control in ARTs organized a physical workshop on quality control in IVF lab on 26th March. It was a very successful workshop in quality control at Sri Aurobindo University with more than 50 embryologists all over the country, and it was attended by Dr. Asha Bakshi Madam with leading embryologists of Central India as faculty. And we would like to thank Shivani Scientific Industries for their scientific support, and also the involvement of the entire MP IFS society members like Dr. Anuradha, Dr. Kunjan, all of them joined the program under the leadership of Dr. K.B. Nair and Suryan Kumar ma'am, with their wholehearted support to our endeavor. Thank you.
Thank you so much, ma'am. Thank you so much, ma'am. Today's webinar is in association with IMA Batul and Obstetric Society Batul. I request Dr. Deepti Rathi to introduce IMA Batul President Dr. A.K. Pandey sir and Secretary Dr. Yogesh Pandagre sir. Over to Dr. Deepti ma'am.
इंट्रोड्यूस करवाती हूँ डॉक्टर आदरणीय डॉक्टर A.K. पांडे सर। डॉक्टर A.K. पांडे सर ऑप्थेल्मिक सर्जन है। ये आईएमए बैतूल ब्रांच के प्रेसिडेंट है और पिछले 40 सालों से भी अधिक समय से डिस्ट्रिक्ट हॉस्पिटल में अपनी सेवाएं दे रहे थे। अभी 2 साल से रिटायर हुए हैं और अभी अपने प्राइवेट हॉस्पिटल में अपनी सेवा दे रहे हैं। और डॉक्टर योगेश पंडाग्रे सर, ये सर MD मेडिसिन है। सर संजीवनी हॉस्पिटल बैतूल के संचालक है। सर आईएमए बैतूल ब्रांच के सेक्रेटरी है और सर बैतूल के आमला विधानसभा क्षेत्र के माननीय विधायक भी है। आदरणीय A.K. पांडे सर और योगेश पंडाग्रे सर का मैं इसमें वेबिनार में स्वागत करती हूँ।
Thank you, Deepti ma'am. Now I welcome all the chairpersons of the webinar. Dr. Pratibha Raghuvanshi. She is obstetrician at Batul and practicing since 10 to 12 years at Batul. And Dr. Aruna Chavan ma'am. She is obstetrician at Batul and practicing since 10 to 12 years. And Dr. Lipi Patnakar, and she is obstetrician at Batul and practicing since 14 years in the Batul. Thank you all of you to this webinar. Now I invite Dr. Smita Dengle ma'am. She is obstetrician and fetal medicine specialist at the Bansal Hospital, Bhopal. Over to Smita ma'am.
Thank you so much, Neha. Thank you for the introduction. And let me just get over to the talk so that we can start with our academic activity. Today, I'm going to speak on second trimester marker. And this is a very important point that we all fetal medicine people speak of. What exactly are second trimester markers? Let us deal with that in detail. So any pregnancy, we do screening of every pregnant lady. And in that we see for the fetus and the mother. Fetus, we need to know the congenital abnormalities. For that, we see the structural defects and we see for the chromosomal problems. For the mother, we screen her for the preeclampsia, small for gestational age or growth-restricted baby or the prediction of stillbirth, and we screen them for a preterm delivery. We do all this by history, the biophysical markers, the biochemical markers, and the ultrasound characteristics. Chromosomal abnormalities, what we talk about. Now let us know in detail. They can be either numerical problems or they can be structural problem of the chromosome. Now numerical problem, as we all now commonly know, it can be trisomies. Like all the chromosomes, they are in two, they are pairs. So it can be in 3 copies. So it can be trisomy 21, trisomy 18, trisomy 13. These are the commonest one that we come across. Or it can be monosomy, like Turner's syndrome. It can be triploidy, where all the 23 ones, they are in 3 copies. Or it can be mosaic baby. Now, the structural chromosomal abnormalities which I speak of, it means either deletions or microdeletion, like 22q microdeletion. It can be translocation of the structure of the chromosome, or it can be the genetic mutation. Now, Down syndrome is the commonest one that we come across. So for that, we do first trimester screening, or if somebody has missed the first trimester screening, then we do a second trimester screening for them, or for anybody for that matter, we do first and second trimester screening for all of them. I'm very sorry for this spelling mistake of screening. Now we do NT scan, which has got a sensitivity of 85%. We do double marker. When we combine both of them, we get a sensitivity of 90%. Most of us know that we have a NIPT test, which is a blood test, which has a sensitivity of 99%. And the best test is a combined test. For second trimester, I do a genetic sonogram, that is the anomaly scan. Then I have a second trimester quadruple marker. Here also I can do an NIPT test. Now when I move ahead, I tell sonography is to be done. So what do I do in sonography? I see for the structural abnormalities. Now, there are certain group of abnormalities which are particularly known for those trisomies or chromosomal abnormalities, or they come in bunch, they move in groups. But apart from these structural abnormalities, there can be soft markers. Now, what exactly do I mean by soft markers? So these soft markers are non-anomalous variations in the fetal anatomy. So they are not the fetal defects. That's the important point I want to stress on. They're a part of genetic sonogram which are performed in second trimester. They're often transient and they may disappear as the pregnancy progresses. They're frequently seen in normal fetuses as well, an important point. Now they increase the underlying risk, but they're not diagnostic of fetal aneuploidy. So the important thing is, it is not diagnostic. When you come across this kind of a thing, it is to be further looked into and tested. Don't take decisions based on the soft markers. Now, soft markers have been assigned a likelihood ratio, which are used to calculate the risk for the fetus to have Down syndrome. We're going to speak in detail about this. So what are soft markers? They can be a number, whole log list is there. It can be a echogenic intracardiac focus. It can be absent nasal bone, hydronephrosis, hyperechogenic bowel, ventriculomegaly in the brain, then increased nuchal thickness. I'll take everything in detail. Short femur, short humerus, aberrant right subclavian artery. It can be single umbilical artery, a choroid plexus cyst, sandal gap, or small ears. Such kind of things you must have seen in the reports, the ultrasound reports that come to you. So many markers. So there has been a meta-analysis of the second trimester markers for trisomy 21. It's an important paper which we look up to. And after this paper has been there, it has assigned a likelihood ratio for these markers. And every time I come across a marker, I see what is the likelihood ratio for that particular marker. So what is this likelihood ratio? I'll try to simplify the things. Likelihood ratio, if it is positive, that means the probability of the disease is increased if this test is positive. That means if I find this marker, then the likelihood ratio or the probability is increased for trisomy 21. A negative likelihood ratio means the probability is reduced. Now, these markers have certain likelihood ratios, and if the likelihood ratio is less than 1, then we call it as minor marker. And if it is more than 1, then we call it as a major marker. So in this list, you can see now that cerebral ventriculomegaly, increased nuchal fold, echogenic bowel, they all have marker likelihood ratio more than 1. Whereas this aberrant right subclavian artery, the absent or hypoplastic nasal bone, they all have a likelihood ratio more than 1. So they are major markers. So once I come across a major marker, I think seriously that what do I do next test for this baby to find out whether this baby has Down syndrome or not. Now, if I don't find any marker, then there is 7.7-fold reduction in the risk. By this meta-analysis, I have this conclusion. So what is my approach to the soft markers in second trimester? If I find a soft marker, I look for other markers as well. And then I calculate the risk of aneuploidy based on this likelihood ratios, and then I go for counseling. It is low risk if the risk is less than 1 in 250. It is high risk if it is more than 1 in 250. This is another way I would present it. And it is important to see where the scan has been done. Does the person who has scanned is able to identify them? Is the person able to calculate the risk based on their likelihood ratios? Now, though echogenic intracardiac focus, the EIF has got a low likelihood ratio. It's a minor marker, but I will deal with it first because it is the commonest one that we come across, and it is the most common reason I find referral to my OPD. So I see an echogenic intracardiac focus in 4-chamber view of the fetal cardia, especially when I see a apical or basal view. It is what exactly it is. It is a discrete echogenic area within the cardiac ventricle with brightness equivalent to that of bone. So it is a white spot that I see, and that is what the patient also says. It does not produce any acoustic shadow. These are the ultrasound characteristics if I try to describe it. And it represents the microcalcification and fibrosis of the papillary muscles or the chorditendinae. It is not associated with any myocardial dysfunction or structural abnormality of the heart. That's an important thing to know. It will neither become any heart defect. So don't worry and don't let the family also panic about it. And it often disappears later in the pregnancy or postnatally. It can be unilateral or bilateral. Though we see it in the early NT scan time also, but we report it at the second time of the mid-trimester scan. It can be single or multiple. The size usually varies 1 to 4 millimeter. Even if it is bilateral or multiple, it does not increase the risk. The likelihood ratio remains the same. It is less than 1, and whatever is the risk at the first trimester scan, it remains the same even after I see a echogenic marker. I'll let you know what do I mean by this thing. The importance of this is that it is even seen in euploid fetuses. That is normal karyotype fetuses also. It is seen in 4 to 7% of the babies. It is more common in Asian mothers' baby, but it is associated with Down syndrome also and other aneuploidies also. So I need to know that the likelihood ratio though less than 1, but then how do I counsel the family? So isolated EIF does not increase the risk, but then how do I counsel, or shall I let it go? Is it unnecessary to cause the parental anxiety? So I need to know what was her first trimester combined risk. So in my previous lectures, I think, thoroughly told about what is first trimester combined risk. It means what was her NT scan risk and the NT scan plus double marker combined. So here you can see that her trisomy, for example, this patient, her first trimester trisomy 21 risk age-related was 1 in 179 and adjusted risk after the combination of NT and double marker was 3,500 something. Now I go to her second trimester risk assessment where I have taken this paper's likelihood ratio and I put intracardiac focus present and all the other ones absent, and considering both the first trimester screening, second trimester marker, her risk remains almost the same. 1 in 179 is her age-related and adjusted is almost the same, 3,700. So it remains same as what it was there in the first trimester combined. But it is important, was her first trimester risk assessment done? So I go back and I say that a first trimester combined risk assessment is very important for every pregnancy. We cannot say that, okay, we will do one scan at 20 weeks or 18 weeks and sort out the problems then. We have to invert the pyramid of care and start sorting out problems at first trimester. So we have to document this finding. We have to discuss with the family. We have to tell them that, see, this is the first trimester risk. It remains the same. And it has to be the informed choice by the parents and the family if they wish to do any further test or they wish to stop the screening test here. The second marker that we come over to is the nasal bone. Nasal bone is also a soft marker for screening for Down syndrome. There are very specific technicalities to see this, and we take 3 measurements of this nasal bone and we record the longest of them. Two images are there. The first image is showing the nasal bone is present in that image. And the second one, you can see the marked difference between both of them. The second one, the nasal bone is absent. Now, in trisomy 21 fetuses, there is delayed maturation of the ossification center of these nasal bone. Now, there are multiple combinations that can happen. The nasal bone, it can be unilateral absent, bilateral absent. It can be hypoplastic. Hypoplastic means it is small for that particular period of gestation. It can be present on one side, absent on one side. So in that case, I will consider that as nasal bone is present. Now, how do I report it? It can be a subjective reporting or an objective reporting. Subjective, some people may say it is shorter, thinner, less echogenic, but we always prefer an objective definition. We take either a single predefined threshold of less than 2.5 millimeter. We take a cutoff of that, or we can go by gestational age-based threshold. Either I take 2.5 centile or 5 centile for that period of pregnancy. That means at 18 weeks, this is the centile, or 20 weeks, this is the centile. Or somebody may say that I will take multiples of median. So these are various objective ways of defining the nasal bone, whether it is normal for that period or not. For our own Indian population, we have a specific centile chart and we follow that. Now, importance for this is that even the euploid fetuses may have, the normal karyotype fetus may also have an absent nasal bone, but absent nasal bone is associated with trisomy 21 up to 60 to 70% of them. So it is important to sort this problem out. Even I had presented my paper at World Congress where I had taken the cutoff of 2.5 millimeter. And if we take that, there is 70% reduction in invasive procedures if we take that particular cutoff of 2.5. Now, this absent nasal bone has got a likelihood ratio of 6.5, a pretty high one. So if I take this into calculation, the risk calculation shows the difference. Like background risk for this particular patient, the age-related risk is 979. But if I take the marker of absent nasal bone, it becomes, the risk for trisomy 21 becomes 1 in 149, pretty high risk. Then the family has got a choice of doing further tests if they wish to. The next one is the nuchal fold thickness. It is the nuchal fold thickness at the posterior aspect of the neck. It is one of the most specific marker for Down syndrome in second trimester. And technical difficulties have to be overcome. We have to take a very particular image where we see the CSP anteriorly, the cavum septum pellucidum, that cerebellum has to be seen. And then we take the measurement of the neck skin in that plane. A very important thing that undue pressure on the fetal head and hyperextended neck, they will give a false positive result. So whenever I come across a measurement of increased nuchal fold thickness, I will check it 3-4 times that whether is it a technical problem or is it really a increased nuchal fold thickness. We take a cutoff of 6 millimeter as the cutoff. It can be a de novo finding in second trimester. By that, I mean that NT may be normal over there, but here I am finding it now. Or it can be a persistent increased nuchal, increased NT persisting over to second trimester. It also has got a high likelihood ratio of 3.7. And it is commonly associated with Down syndrome, even seen in normal fetuses also. But the likelihood ratio is more for Down syndrome. Here also we do the calculation based on the software where we follow the second trimester marker meta-analysis paper. The next is the URSA. URSA is aberrant right subclavian artery. It is very important to see when we are seeing the fetal heart, that time only we screen the babies for this aberrant right subclavian artery. It is a newer marker as compared to the previous markers. And it is found in children or babies with congenital heart disease, and even in adult population also we may find it. So when I'm seeing the heart as 4-chamber and the outflow tracts, then the 3-vessel trachea view. After that, as I'm coming up in a segmental sequential analysis and I'm decreasing the PRF of my color Doppler flow, then I come across and I see this right subclavian artery, whether it's a normal course or an aberrant course. I hope this video works for me over here. Yes. Here, a normal course is in front of the trachea, but if it is an aberrant course, this aberrant right subclavian artery, it goes behind the trachea. So it is very important that we see it in every fetus, because once we make it a habit of seeing, then only we will be able to pick up it in an abnormal one. So normal right subclavian artery is a branch of brachiocephalic artery which courses to the right in front of trachea. But aberrant right subclavian artery is the fourth branch of aortic arch which courses behind the trachea and the esophagus. So we have to see it in every baby so that we are at good practice to see, and we are able to pick it up when it is in an aberrant course. So prevalence is in normal individuals, it will be 1 to 2%, but in trisomy 21, it is 28 to 37%. Normal karyotype with congenital heart disease, in 3% of them we will see. And association of this with, whenever I find URSA, the a priori risk for trisomy 21 increases almost 4 times. Even for T18, 12-fold increase is seen. Even for 22q microdeletion, I may have URSA. So it is not only the trisomies that I'm worried about, it can be something else also. And rarely it causes dysphagia, though it is a very rare thing, but I'm more worried for the chromosomal problem. So when I see this, I do a detailed anomaly scan. I do a fetal echocardiography completely to note the additional markers, and additional marker for 22q microdeletion. Thymic aplasia is important thing that I look for. I go for fetal karyotyping, including analysis for this microdeletion. And then, I mean, this paper tells me that it is much more common in chromosomal defects, particularly T21, and there can be increased incidence of intracardiac malformation. So it is important that I do a complete fetal echo also. As I said, the likelihood ratio is 3.9 for this marker, and this is how we calculate the risk for the T21 when I find a URSA. Next important one is ventriculomegaly. For this also, we follow the technique that the axial plane of the fetal head is taken, where I find the midline falx and the CSP is seen in anterior third. I see the parieto-occipital sulcus, and at that particular place, I place my calipers on to on. They are perpendicular to the ventricles. The putting of the calipers is very important. Otherwise, I will erroneously measure the ventricles and it will give me false reading. And normal will always be up to 10 millimeters or less than 10 millimeter at any gestation age. Whenever it goes above 10 millimeter, I put it into category of ventriculomegaly. So it can be mild or borderline. It can be unilateral or bilateral. And then it has got multiple associations. It can be isolated. So if it can be with aneuploidy, especially Down syndrome. It can be with fetal infections like toxoplasma or CMV. It can have other cerebral structural malformations. So it can have cortical malformations, or it can have absence of septum pellucidum with it. It can have agenesis of corpus callosum, agenesis of cerebral vermis. So cerebral or non-cerebral defects and genetic syndromes, they are found in around 50% of the cases. So the moment I see that there is ventriculomegaly, I see the baby completely again. I may find some other multiple malformations. I may not find. I may find some stigma of infection or some other abnormality. So I have to see this baby again all over and look for other things. I will do a complete neurosonography for this baby. I will discuss the invasive testing for karyotyping and array. I'll also discuss the infection part screen. Important thing that maternal blood testing for antiplatelet antibodies if I see some evidence of brain hemorrhage also. And if the pregnancy is continuing, then a fetal brain MRI more than 32 weeks for diagnosis of abnormalities of neuronal migration. Though lissencephaly, I can diagnose to an extent by ultrasound also, but MRI more than 32 weeks give me a better idea, and then we will be able to discuss the things better with the family. So whenever I come across this ventriculomegaly, ultrasound scans every 4 weeks to monitor the evolution. Then majority of the isolated ones, they are non-progressive. And risk of the progression of ventricular dilatation is around 15%. If anomalies are not visible initially, in 12.8% of the fetuses at further assessment pre and postnatally, progressive ventriculomegaly has got a worse outcome than non-progressive ones. And it may be associated with neurodevelopmental outcome, but if it is around mild one, 10 to 12 millimeter, then more than 90% of the cases, they are normal. Neurodevelopmental delay is more seen when there's a progressive ventriculomegaly. So isolated ventriculomegaly also, there is a risk of neurodevelopmental disorder, but the absolute risk is less. So it is something very tricky. The moment you tell to the parents and the family that there's something wrong with the brain, they are really aghast. That something wrong with the brain means the thing that there has to be developmental disorder only. So it is a very sensitive issue that we have to speak to them and discuss with them and tell them clearly that there are certain screening things that we can do and then sort out the things. Recurrence of this ventriculomegaly, if it is isolated, the rate is less than 1%, but it increases to 5% if there is a history of affected fetus or sibling. Like previous pregnancy also, there has been same kind of a thing, then the percentage increases. If it is a part of infection in that pregnancy, then there is no increased risk. If it is a part of trisomy, then 1% more than the age-related risk at that time. If it is an X-linked hydrocephaly, then 50% of the males, they will be affected. And if it is associated with alloimmune thrombocytopenia and no treatment has been done, then definitely 100% recurrence will be there. It has a LR of 3.8. And this is how we do the risk assessment in our software. So the markers that we have discussed is EIF, absent nasal bone, ventriculomegaly, and increased nuchal thickness, which have got a higher LR, that is, they are the major markers. Now, certain markers which have got a low likelihood ratio, like hydronephrosis. This also we come across very often, that the renal pelvic dilatation is there. So renal pelvis also we measure in axial view and we see it in all the fetuses. So mild hydronephrosis is a marker for aneuploidy. And renal pelvis measurement also less than, it has to, at particular gestation age, the values have been given. But anytime more than 10 millimeter, it is considered at risk for structural abnormality. So whenever you see a report which says that the renal pelvis are prominent, then you have to see what is the gestation age and accordingly. So gestation age-wise, if I see, the second trimester, I'll say mild when it is 4 to 7 millimeter, moderate 8 to 10, severe more than 10. Third trimester, 7 to 9 is mild, moderate is 10 to 15, severe is more than 15. But if it is severe anytime, think of structural problems more than the risk of aneuploidy. Hydronephrosis, chromosomal defect, low risk in isolated forms. We always have to see the contralateral kidney, whether it is multicystic or there is ectopia of the renal other moiety, or there is renal agenesis, or there are any other associated syndromes which can be found in around 5% of the cases. So if I come across this, I have to do a detailed ultrasound examination, and karyotype should be offered only if other markers are present. We have to follow this baby every 4 weeks to monitor the evolution of the hydronephrosis, and we have to assess the amniotic fluid. So keep this baby under follow-up. Hyperechogenic bowel, I call bowel as echogenic bowel when its whiteness is equal to that of the bone. And whenever we are doing the assessment, we usually use a low frequency transducer, usually 5 megahertz or less. And because high frequency transducer might give you a confusion of hyperechogenic bowel. And whenever you come across such kind of a thing, then change the gain and try to see whether is it really a hyperechogenic bowel or is it because of the gain that you are seeing that. It can be focal or diffuse, and there are 3 grades to echogenicity. And we have to differentiate it with meconium peritonitis. And that is how we have to, first of all, be very sure whether it is hyperechogenic bowel or is it our technical things that is making us feel that. Now it is associated with aneuploidy, and it may be associated with fetal growth restrictions or intrauterine demise. It can be because of the intraamniotic bleeding or cystic fibrosis or congenital malformation of the bowel, congenital viral infections, even in alpha thalassemia. And if it is a normal variant, up to 70% it resolves. So we have to rule out all these things if we come across a hyperechogenic bowel. Even if it is isolated, we have to do a fetal karyotyping. And we have to see the maternal serology for infection. Especially, I would say IgM, IgG with avidity has to be done, because whenever anybody sends this toxo CMV, they're scared with that report that IgG has come positive. But IgG positive means a past infection. But avidity I require because a high avidity means it's a really a past infection, because many a times the IgM, which gives you the idea of present infection, the graph of that IgM has not gone down completely. So if it is a report which says IgG with high avidity, it means it is a past infection and that is not going to harm the fetus. So always when we send these samples, we have to send it as IgM, IgG with avidity. Then if I speak of cystic fibrosis, then we have to see the ethnicity. And even in India, cystic fibrosis is seen. Though all the mutations of cystic fibrosis are not known, but still we have to keep that, consider that, and accordingly put into the scenario and try to find out what can be the, in relation to this particular baby. The third trimester bowel complications like atresia, volvulus, bowel perforation, they also can lead to such kind of image. And serial growth scans when there is a risk of fetal growth restriction. So this is what we recommend when we come across a hyperechogenic bowel at the ultrasound. Short, long bones, yes, bones less than 5th centile for that particular gestation age. Because whenever we are doing a biometry, we follow the gestation age, whether is the baby growing according to the gestation age or not. So short humerus, they are associated with Down syndrome. Even short, long bones are seen in euploid fetuses, but that percentage is less. And we have to always differentiate this thing with the skeletal dysplasia or early onset fetal growth restriction or a constitutionally small baby. So we need to know whether the family, what is the general height of everybody, or are there any members who are really of short height. So this is how we try to find out that is it a constitutional small baby, or is there is a familial short height, or can this baby be skeletal dysplasia? Dysplasia will always have other stigmata of skeletal dysplasia. Early onset fetal growth restriction, we may find uterine artery Dopplers showing haywire right from beginning. So certain points in history will let us have particular differential diagnosis. Next is choroid plexus cyst. This also we come across very commonly, which are the cysts in the choroid plexuses. It can be single or multiple, unilateral, bilateral. They are mainly associated with trisomy 21 and sometimes with trisomy 18 and possibly with T21 also, but more so with 18. And trisomy 18 babies, they show many problems on scan. So that is how we'll be able to pick them up better. Like trisomy 21, they may not show any issues on scan, but trisomy 18, they show many other abnormalities or many other markers. So a detailed ultrasound examination for other markers is required. If it is only isolated finding, then there is no need for invasive testing only for choroid plexus cyst. We can see what is her combined first trimester screening test and how is the screening result at that time. Single umbilical artery is also a very common finding. Incidence of aneuploidy is around 30%. And it is associated with other problems like genitourinary or cardia. It may have adverse pregnancy outcome in around 15 to 20% of the cases, associated with miscarriage, growth restriction, intrauterine demise, preterm delivery. But single umbilical artery in isolation has a good prognosis. Sandal gap, that is the medial displacement of the great toe. It is also seen in Down syndrome, but as an isolated finding, it is not that that particularly associated with Downs. It can also be a normal variant. You can look up to the parents' toes, that how is the structure for the mother or the father. So if it is seen along with other markers, then you might consider it. Small ears is also a thing which may have an increased incidence of aneuploidy like Downs or 13, 18. And we have to see it in every scan. Either you go for a coronal view or a parasagittal view, and age-based, gestation age-based charts are to be followed for them. So fetal ear length, short ear length is associated with fetal aneuploidy. It helps us in predicting them. So with all these markers, we get to know that if it is isolated marker, then we need to know the likelihood ratio and then the a priori risk, that is the background risk that changes. And if the first trimester scan has been done and first trimester screening, combined screening is there, that will also change once I see these markers at the second trimester scan. If I don't see any marker, then there is 7.7-fold reduction in the risk. So the lessons learned from this is, if I see one marker, I look for more. If I see anomaly, I look for more. And then I do a complete investigation in the pregnancy to assess the risk of recurrence or to assess the risk of aneuploidy. Thank you.
Thank you so much, ma'am, for beautifully explaining about the second trimester screening. I think you have covered everything about the second trimester screening. Is there any questions?
Chat box or anything there? Shilpi, if you can see any questions? Either the things are very clear or it was not at all.
I just want to have a query. Hi, Dr. Smita. Hi, how are you?
Hello, all fine. How are you?
All good, all good. Just wanted to clarify. I have one patient who is like more than 8 years infertile. Then we did IVF twice. IVF failed, but now luckily she conceived. But now in the 5th month, maybe otherwise level 2 was fine. Dual marker were fine. Level 2 pe maybe I missed, or maybe the radiologists have not written anything, but I could make out now at the 8th month. FL, the femur length is 2 weeks lagging. Only femur length.
Okay.
The rest, everything is all fine. So do you
Is
think,
she diabetic?
no, non-diabetic, no other medical comorbidities, nothing is there. So I was just thinking, now it's already 8 months plus. So,
Yes,
and maybe
true,
that
true.
much infertility.
See,
so
really, I mean, isolated femur length being short is really a big issue, a problem. And there are multiple differentials for that. So when at 8th month only I'm seeing this, I would like to go back and see whether her dating was all correct.
That was
now,
correct.
Since she is a IVF pregnancy, we know the date of conception and everything. Then from 20 weeks onwards or anomaly scan onwards, I would like to put all her biometric findings on a chart. And I would like to see whether the baby has been growing on the same centile. And was the femur length always right from beginning like this only? So we will compare it right from 20 weeks onwards. How is the growth of this baby right from that time? Because it happens that last we see that is it towards the term that we are seeing the small length of the long
on
bone.
5th month, I could make out 8-9 days delay. Now it's like 2 weeks, maximum 2 weeks lagging. Nothing else.
But
otherwise, no other.
Is the abdominal circumference also coming down? That is another thing that you will have to look into. So if the abdominal circumference is also coming down and femur length also coming down, then the growth is the one that is going down. If it is only the isolated one which is going, then I would like to see whether the sugars are normal or not. Then what is the height, general height of the patient and the general height in the family? How is it going?
That's a little not short.
That
is not hard. That the female is like hum dono ki height jaisi, 5 maybe, not more than, not less than that.
So that can be seen. Not very tall parents.
Not very tall parents. Yeah, 5.
Yes.
So that may be, no?
Maybe constitutional. But then we will always compare it. How was it before? So previous scans and now the comparison of how it is going. And I just hope all her screening stuff is clear. All her aneuploidy screening part is clear.
These.
Sure.
I'll send separately then, Smita. I'm just waiting for today's scan for her to a better radiologist. So it's just waiting for that report today.
Okay.
Nice presentation, I must say.
Thank you. Thank you. Thank you.
Is there any other questions?
Any
one
chat
more
box
one.
you can see? Yeah.
There's hardly anything in the chat box, I think.
Yeah.
There's nothing in chat box. One thing just want to be clear, but if we have done dual marker in 11 to 14 weeks, do you think we should go for quadruple also, or dual marker is sufficient? Level 2 is also normal. Level 2 scan, 4D scan is normal. Like in this patient, same patient, I'll just tell you.
If the first trimester screening has been done, we have done a double marker, and we have a combined first trimester screening, that is the first NT scan and the double marker, and combined result we have, then we have already achieved a 90 to 95% of the screening. So, and our anomaly scan or the target scan, level 2 scan is also good. So we have achieved the maximum of the screening for this baby. Then quadruple is not required because quadruple gives me a sensitivity of around 75% maximum. So when I am already at 90 to 95, then quadruple does not add much to it. So our target, that is the reason, is always NT plus double marker and a anomaly scan or a level 2 scan.
Okay, so that means this is better. I mean, not like only quadruple and level 2.
No, if she has
dual marker is better.
Dual marker plus NT, both of them combined.
Okay, that is.
And suppose if she falls into an intermediate risk at this combined, then we go for a quadruple and then we combine everything. And we call it as a sequential screening.
Okay.
So NT plus double plus quadruple and the genetic, all four combined, and then see how is the risk now. That ways. Okay. But if she is at low risk, then quadruple alone is not required.
Not okay. Fine. I was just clearing for the same patient actually. So everything I've done earlier. So a little worried about that result of that patient as well.
Yes, it happens.
Yeah.
But it will be fine. It will be fine.
Oh, hopefully. Thank you. High risk patients, so a little worried.
Yes. It will be fine. Okay.
Nice. Bye.
So, anything else, Neha?
Ma'am, there's no more questions.
Okay. So we call it a day.
So can we wrap up, ma'am?
Yeah. You can. You can give the vote of thanks, I think.
Yes, ma'am. Yes, ma'am. Okay. I would like to thank Dr. A.K. Pandey, sir, Dr. Yogesh Pandagre, sir, Dr. Priya Bhave Jitavar, ma'am, Dr. Tina Gupta, ma'am, Dr. Shushmita Mukherjee, ma'am, Dr. Smita Dengle, Dr. Mamta, ma'am, Dr. Bharti, ma'am, Dr. Deepti, and Dr. Pratibha, ma'am, and Dr. Aruna, ma'am, and Dr. Lipi, ma'am, and whole IMA Betul, and Obstetric and Gynecology Society Betul, and IMS MPIFS chapter. Thank you, everyone.
Okay, thank you. Thank you. Bye-bye. Bye-bye.
Thank you.